tumors.
Okay. Well, thank you so much, and I would like to thank everyone and the organizers for allowing me to discuss today about neuroendocrine tumors. I work for the government, so I don't have disclosures. Today we're going to epidemiology of neuroendocrine tumors. We're also going to understand different clinical presentations associated with neuroendocrine tumors, as well as determine what is the clinical findings and characteristics that help us decide about different treatments for neuroendocrine tumors, and at the same time, what are the all treatments available in the advanced setting. Neuroendocrine tumors, as we all know, are considered a rare and very interesting group of malignancies. That said, I have to say that Dr. Tassari, who initially published the first epidemiological studies about neuroendocrine tumors, is reanalyzing the data, and we think that by the time he published this, we are not going to think that neuroendocrine tumors are so rare. That said, there's still a lot of challenges in terms of the management of neuroendocrine tumors. As we can see here, we have the incidence of neuroendocrine tumors, and we can see that it's really striking the rise in the incidence of neuroendocrine tumors compared to other neoplasians who has been stable, but we can see that the incidence has been rising. And you may ask why we're seeing this, and one of the reasons is because we're doing more colonoscopy, endoscopy that allows to diagnose patients more in the earliest stage. Also, we have better diagnostic tools as well now with the dotted scans and other functional imaging modalities that also help us to diagnose these neuroendocrine tumors. And also, one of the questions that we have, if there is any epigenetic changes that is also having an effect on the rise in neuroendocrine tumors, and that's also a research question that we wanted to understand. We also know that neuroendocrine tumors has also increased as well based on sites. As we can see, there is a rise in neuroendocrine tumors in the lungs, as well as the rectum, pancreas, and small bowel. Now, the nomenclature of neuroendocrine tumors is quite complex. And as we can see here, we have from well-differentiated neuroendocrine tumors to the neuroendocrine carcinomas. And we're going to discuss a little bit more about this, but well-differentiated neuroendocrine tumors, these tumors have an indolent behavior. However, the neuroendocrine carcinomas has more of a dismal prognosis. How do we know between which one is well-differentiated versus the poorly differentiated neuroendocrine carcinoma? It's a lot on the Ki-67. So we can see grade 1, Ki-67 is less than 1%. Grade 2, Ki-67 is between 3 and 20%. And now I do want to focus a little bit on the grade 3 well-differentiated neuroendocrine tumors where the Ki-67 is greater than 20%, but it's usually less than 55%. And the reason why I want to focus on this one is because there is some challenges in treatment. And sometimes when we look at the pathology report, they say grade 3 neuroendocrine tumors, and we think that that needs to be treated as a small cell lung cancer regimen. But very important, and somebody mentioned earlier, that the pathologist is very important as well to help us determine whether this is a well-differentiated NAT or grade 3 NAT, or if this is a poorly differentiated or NAC. And the reason why is because there is different treatment algorithms between the well-differentiated grade 3 versus the neuroendocrine carcinoma. As I say, neuroendocrine carcinoma, usually we use the cisplatin and etoposide, and we follow the same treatment algorithm as small cell lung cancer. That say for the well-differentiated grade 3 neuroendocrine tumor, we use other treatment options such as Folfox, Kbox, Captent, and also the patient is able to express the somatostatin receptor, then 177 lutetium, though that they can also be another treatment option. One thing, a lot of the discussions between yesterday and today is about precision medicine and also about determining biomarkers, predictive, prognostic biomarkers. But I have to say for neuroendocrine tumors, we're not quite there. That said, I think while the techniques are improving, as well as we're testing more patients with neuroendocrine tumors, at the same time, we can also develop more drugs that target specific mutations. I think this is going to change. But up to today, we don't have any mutations that can be targeted with drugs. That said, you may ask, do we need to send the tumor for Foundation 1? And yes, I mean, we can certainly do it. Sometimes that can help us understand more about the biology of the tumors, but not necessarily the fact that we're going to find a targetable mutation is going to be quite low. Just lastly, patients with well-differentiated neuroendocrine tumors are more avid on DOTA scans, but once they become more aggressive, they lose the somatostatin receptors, and that's when FDG PET scan is a better scan for these patients. Now, adding to the complexity of these neuroendocrine tumors is that these neuroendocrine tumors can also produce hormones. Based on the location, as we know, all neuroendocrine tumors, it can be anywhere in the body. At the same time, based on where the neuroendocrine tumor is located, they have the capacity to produce certain hormones. And based on the hormones that they produce, they have very specific symptomatology. And just to kind of like also add into the complexity of the management, not only as a medical oncologist, we need to treat patients in advanced settings using different systemic therapies, but at the same time, we need to do something that helps us also control the symptoms related to the hormones caused by the neuroendocrine tumors. And today, we're only going to focus about the small intestine as well as the pancreas neuroendocrine tumors. Small intestines can often produce serotonin, and these excess of serotonin can cause carcinoid syndrome, and at the same time, pancreas, up to 40%, here in the United States, they say 10 to 30%, in Europe, up to 40% of pancreas neuroendocrine tumors can produce hormones, and this is the different hormones they can produce. Based on what hormones they produce, they have different symptomatology, and we need to implement different management as well for what hormones they produce. Now, neuroendocrine tumors are heterogeneous. It's not yesterday they were discussing about radiology, that sometimes one side may fit all for radiology treatments, even though there may be some also complexities of the treatment, but for neuroendocrine tumors, that's not the case. The management of neuroendocrine tumors is quite personalized from patient to patient. And that also will depend on how much is the tumor burden that the patient has. We also need to determine whether the neuroendocrine tumor has metastasis only in the liver or is widely metastatic. We need to understand also whether these neuroendocrine tumors are stable, because as I said earlier, these neuroendocrine tumors can have an indolent growth, or we need to determine whether they're stable or they have progressive disease. We also need to determine what is the site of neuroendocrine tumors in the GI tract, because we have different treatment algorithms as well. We also need to understand whether they're well differentiated or poorly differentiated. We discuss about hormones. We need to determine whether functional or non-functional. We also need to determine whether the neuroendocrine tumor expresses somatostatin receptor or not, because now with the treatment of 177 lutetium dotatate, that could be a treatment option for these patients as long as they express the somatostatin receptor. So this has been the treatment landscape, and as you can see, it was in the before the 2000s that there was not that many treatment options for neuroendocrine tumors, but it has been on the last decade that we have seen an explosion of different treatments of neuroendocrine tumors, and we're going to discuss one and when to use these different type of neuroendocrine tumors. But this is also an exciting time for us as a net expert that sees only these neuroendocrine tumors, because now we can see that there are many treatment options that we can add to our toolbox that we didn't have before. Oops. But with that, the management is still quite complex. And the reason why, as I said earlier, it's not like one size fits all. So when we see a patient with neuroendocrine tumor, we need to determine whether the tumor is functional, is causing tumors, because we need to then implement different treatment options for those patients. At the same time, we need to determine as well what is the volume of disease, where the tumors are located, because that's when we need to implement different therapies depending on what we feel is the best for the patient. As we can see, we are going to discuss about 170 lutetium dotatate. SSAs is usually our first-line therapy for neuroendocrine tumors. We also have targeted therapies, but the question is when to use it and what type of neuroendocrine tumors. We also have the cytotoxic chemotherapy, which usually mainly for pancreas neuroendocrine tumors, and then to the cisplatin etoposide for the neuroendocrine carcinoma. But at the same time, surgery and liver-directed therapy is still an option for neuroendocrine tumors. There is data that said that if you're able to resect more than 75% of the volume of neuroendocrine tumors, there is a benefit in overall survival benefit. And that's important. Earlier they discussed about the importance of tumor board, and that's the reason why I think it's important as well to discuss is feasible with multiple specialists to decide what would be the best treatment options of patients. I have to say that cytoreductive surgery, some neuroendocrine tumors are underutilized, but that's something that we need to discuss with our surgeons to determine if that's a possible option for our patients as well, because that can also help resect the clock in some of the patients, and that's important as well to take it in consideration. Oh, now we're going to discuss a case. So this is a 65-year-old female that complained with left-side abdominal pain and persistent diarrhea. She underwent an X-lab for persistent left-sided abdominal pain and was found to have small bowel obstruction. At the same time, when they were doing the X-lab, they also found, the surgeon found liver lesions. She underwent a small bowel resection as well as wedge resection of the liver. Pathology was consistent with a small bowel, well-differentiated neuroendocrine tumor with a Ki-67 and less than 1%. So the patient had surgery, and following scans, we saw that there is a rising on the 5-IAA, and the patient has persistent diarrhea. Also, in follow-up scans and anatomical imaging studies, we see that the patient has one liver lesion, and then also is correlated with the dot that they scanned. So what we're going to do next on this patient? I don't know, if anybody wants to raise your hands, you want to do lanreotide? Anybody wants to do lanreotide? Mm-hmm. Anybody wants to do surgery? Dr. Smith? So anybody wants to give PRRT with 177 lutetium dotatate? No, okay. Ablation? It's only one. Yeah. Watchful waiting? Yeah, okay, yes. I mean, I think those are the questions. I mean, those are the options that we always discuss with our patients. And yes, the patient has one liver lesion, but one thing that we need to keep in mind is the patient is quite symptomatic and the patient has persistent diarrhea. In this situation, yes, could we do liver ablation and that can help the symptoms? Yes. Could we do watchful waiting? I don't think I would do that right now because the patient is symptomatic. Again, surgery is too morbid right now. But in this situation, what I agree to give to this patient was lanreotide. And the reason why is because lanreotide has, and that's maybe Dr. Ramirez fellow, so who is a net expert in Vanderbilt here. And then lanreotide is an option that we'll consider for this patient because this somatostatin agonist has two functions. It has anti-tumor activity, but it also has anti-hormonal activity, and it's definitely going to help with the symptoms. And this is just going into the data. This is where the data came from. This is from the PROMET study. That was the octreotide long-acting, as well as from the Clarinet study, which is the lanreotide as well. And as we can see here, in terms of, there was a benefit on progression-free survival on patients that receive octreotide long-acting compared to placebo. So these studies were randomized. They were lanreotide, investigational drug, versus placebo. And that's something that we need to keep in mind as well, considering that this patient has an indolent growth. One thing that I want you to keep in mind is that the patients that were selected to be included in the study, on the sandostatin study, we saw that most of the patient has low volume disease, whereas the lanreotide group, they have more volume disease included on the patients that were studied. That said, as we can see, there is no head-to-head comparison, but we can see the difference in progression-free survival on the patients that receive lanreotide. That said, we always said, like whenever we want to choose an SSA, we always say that it's interchangeable, there is no head-to-head comparison. We say whatever the insurance can approve in those situations. Sometimes I feel that lanreotide is easy to administer. That said, we have seen from patients that may experience more side effects compared to the sandostatin. And that say if a patient have a side effect with lanreotide, you can always change the sandostatin, and as well, if a patient develop too many side effects with sandostatin, you can always change it to lanreotide. And it seems that the patients are able to tolerate better. So we'll continue with our case. So patient experienced worsening diarrhea 12 times per day, and that's with the small bowel neuroendocrine tumors. That's one of the most common symptoms, debilitating symptoms for these patients. Despite getting lanreotide, sometimes instead of every 4 weeks, if the patient is very symptomatic from the hormone excess, we recommend every 3 weeks, and sometimes we recommend some rescue shots. But what are you going to do next? Now, this patient has very symptomatic from his disease in terms of the hormone excess. So what are you going to consider? Are you going to increase the dose of lanreotide? Anyone? Are you going to give telotrestat? Yeah. Lutathera? Everolimus? Or ablation embolization? And yes, the answer in this situation is telotrestat, and I'm going to explain why. So telotrestat is a very interesting drug because telotrestat blocks the rate-limited enzyme that converts tryptophan to serotonin. And because of that, the studies that has been done, we can see that not only by giving telotrestat lower how much circulating serotonin is, but at the same time, based on the study, they also saw that patients decreased the number of bowel movements per day. So this is a very good drug for those patients that have carcinoid syndrome diarrhea, and that's the only indication, is the only FDA approved for carcinoid syndrome diarrhea. In a patient that is very difficult to control the diarrhea, I think this is a very good drug to use. And it's very important as well, as I say earlier, for small bowel neuroendocrine tumors, it's always very important to control the hormone excess, extracellular and intracellular as well. Extracellular with the use of SSAs, intracellular with the use of the telotrestat, because as I say earlier, that blocks the rate-limited enzyme of tryptophan to serotonin, and that definitely can help control some of the diarrheas and as well lowers the levels of serotonin as well, of HIAA. Now, important to recognize carcinoid syndrome, and one of the reasons is because flushing, diarrhea, those are the most debilitating symptoms for the patients, but also I wanted to mention something about carcinoid heart disease, and that's one of the becoming more and more of an issue in terms of management as well, and it's associated as well with increased mortality in patients with neuroendocrine tumors. And there is now more awareness about carcinoid heart disease. I think it's very important that whenever you see a patient with neuroendocrine tumors, a small bowel that's producing serotonin, check the serotonin level, check the BNP. They say that if the BNP is greater than 250, that's when you're going to send the patient to a cardiologist, do a echocardiogram every 2 years in order to prevent the carcinoid heart disease. A lot of these patients may need to undergo valve replacement as well when that happens. Okay. Now we have this patient, we're continuing with the same patient. So the patient has now multiple hypermetabolic tumors in the pelvis, adjacent and involved in the wall of the sigmoid colon, Dr. Smith, small areas of hypermetabolic activity and abdomen and pelvis, and probably additional implants as well in the tumor. And scans also reported the patient has progression of disease. So what are you going to do now with this extensive disease? So are we going to give everolimus? Anyone? How about sunitinib? Anyone wants to give 177, lutetium dotatate? Surufatinib? I'm going to discuss the surufatinib data, or lenvatinib. And that's correct. So we see that this is a dotatate scan, has progression of disease, very avid tumors on dotatate scans. And I mean, I'm sorry to ask Dr. Smith, would you do surgery on this patient? Even though if you're able to resect more than 75 bulk of disease, is that going to, or maybe you need more information before that, most likely? No surgery, okay. Okay, that's true. So this is an indication to give Lutathera, or 177 lutetium dotatate. So this is the data from the Netherlands study, whoever is familiar with this data, and we can see that there is a benefit on progression-free survival of patients that receive 177 lutetium dotatate. And one thing is that this is also a randomized study, and it was randomized to either patients getting 177 lutetium dotatate or getting high-dose sandostatin, and there was 60 milligrams every 28 days. That said, I have to mention that this data, when we saw this data, this is very beautiful Kaplan-Meier curves, and that's when we saw also the interim analysis of overall survival. We saw that they were very, very, very excited because we saw this is one of the first drugs for neuroendocrine tumors that has a benefit in overall survival. That said, at 5 years, when they finalized the analysis and overall survival, there were really no difference in overall survival between the two groups. That said, if you look at the median overall survival of patients that receive 177 lutetium dotatate versus the control, which is high-dose sandostatin, there is still a benefit, a median overall survival of almost 12 months. And maybe that can be considered some clinical, is meaningful clinically, and that's something that we need to keep in mind, even though we didn't see any overall survival benefit. One of the questions is like, why we didn't see any overall survival benefit? It's possible they wasn't powered for overall survival. A lot of these patients cross over to get 177 lutetium dotatate. Maybe those are the factors why we didn't see a benefit in overall survival. But that's something to keep in mind, and it's something that we know that Lutathera is a good drug. We know that Lutathera stabilizes the tumor. Response rate is not as robust as other agents that we have used, but it's always an option and in your toolbox to use when it's needed. Now let's discuss another case. This is a 66-year-old male with a history of MEN1. So, and then when he was diagnosed when he was 36-year-old. Clinical manifestation of primary hyperparathyroidism, 3-gland parathyroidectomy, gastrinoma, status post-distal pancreatectomy, splenectomy. At age 56, he was diagnosed with insulinoma. It was bias improved, and as we can see on the scans, also has multiple liver lesions. This is a fasting test that proved that the insulin levels were very high, where the glucose levels were very low. So what are you doing in those situations? What do you want to do? Do you want to give sunitinib? Anyone? Captain? Sandostatin? How about everolimus? How about liver-directed therapy? Anyone? Okay. Well, so in these situations, what I will personally do is give everolimus. And the reason why is because the side effect of everolimus is hyperglycemia. We know that everolimus not only increase glyconeogenesis, but also decrease the insulin secretion from the pancreas, decrease the insulin secretion. And because of that, we see this patient has severe hyperglycemia, and that's one of the side effects. If you see a patient with insulinoma, it's very rare, of course. I think this is an agent that you can definitely consider even as the second-line setting. Usually, I don't use everolimus as a second-line setting. I usually use PRRT or other options depending on what is the clinical characteristics of the neuroendocrine tumor. But that said, this is an instant where I would use everolimus as a second-line setting after SSA. So this is just to discuss the different mTOR pathways, everolimus, so that we have the RADIANT-3 and the RADIANT-4. The RADIANT-3 was for advanced pancreas neuroendocrine tumors, and RADIANT-4 was for lungs as well as for GI neuroendocrine tumors. We can see there is a benefit in progression-free survival. As we can see here, there is not a benefit in overall survival. We saw here on the lungs and GI net that maybe there was a trend in overall survival benefit, but it was not statistically significant. But that's something that we need to see. One of those drugs that we can use in your toolbox. That said, when to use it, I usually don't use it as a second line. It usually will be more my third or fourth lines after all the treatments that we're going to discuss. This is one of my last cases. I know that I started almost 10 minutes late, just to let you know. But so we have a 56-year-old male with a complaint of left upper quadrant epigastric pain. CT of the abdomen identified a mass in the head of the pancreas. And the mass in the head of the pancreas measured 4 by 3 by 3.8 centimeters in size. Biopsy was reported as a grade 2 well-differentiated neuroendocrine tumor, Ki 67 and 15.5%. These are pancreas neuroendocrine tumors. Hormonal evaluation was normal. Then a follow-up scans, there was increase in the size of the pancreas, but as well as increase the size of the liver metastasis. In this case, about 5.8 centimeters in size. In the past, a few months earlier, that was after 6 months earlier, it was very small to characterize. Patient began monthly sandostatin, but despite that, on follow-up scans, reported evidence of disease progression. So we have this patient with pancreas neuroendocrine tumors, has large volume disease, is avid on dotatate scans, symptomatic from the bulk of disease. So what are you going to do next? Sunitinib, anyone? Give cytarabine temozolomide? Lanreotide? Everolimus? 177 lutetium dotatate, or liver-directed therapy. And in this situation, yes, I will certainly give capecitabine and temozolomide. And why is that? Because capecitabine and temozolomide, that's the one that has in pancreas. It's for pancreas neuroendocrine tumors. That's something that we need to really keep in mind. The studies has not been done in small bowel neuroendocrine tumors. Some oncologists may give it, and they have seen some responses. That said, I personally don't use it for small bowel neuroendocrine tumors because we don't have the data that supports that we have the same response that we have seen for the pancreas neuroendocrine tumors, but that we can see the objective response rate with capecitabine temozolomide is quite significant, and that has been one of the highest response rate in all of the treatments available for neuroendocrine tumors. So this is one of the NCTN studies of capecitabine temozolomide. Dr. Pan Kuntz led the study, and we can see here the benefit and progression-free survival here in patients that received capecitabine versus capecitabine temozolomide. We also saw a trend on overall survival, but that say it was not statistically significant. One thing that I want to mention that is very important, because talking about predictive biomarkers, is that they also score MGMT by immunohistochemistry, as well as they measure the MGMT promoter methylation. As we know, in brain cancers, MGMT deficiency is associated with response rate in brain cancers. And this is the study, the first study that we have seen that even though MGMT was not, this predictive biomarker was not on the endpoint of the study, but we saw here that the patients that achieve a response were associated either by low immunohistochemistry score by MGMT, or positive MGMT promoter methylation, indicating MGMT deficiency that is associated with response in patients that receive capecitabine temozolomide. It was difficult also because both patients, they received temozolomide, but that said, we have seen that the patients that had the higher response rate and with the captain has been associated as well with MGMT deficiency. You may ask, do I need to do this? And if I want to consider captain in patients? Not necessarily. It's not validated yet, but it's something to keep in mind. So I think insurance may be an issue there, approval, but it's something to keep in mind. Now, sunitinib. So we know that sunitinib is another tyrosine kinase inhibitor used as well for the management of advanced pancreas neuroendocrine tumors, not for small bowel neuroendocrine tumors. We can see also the benefit on, this was also a randomized study of sunitinib versus placebo. We saw benefit on progression-free survival with sunitinib. Not really remarkable response rates as we have seen with the captain. That said, there has been other TKIs that has been used in the management of neuroendocrine tumors. And the ones I wanted to focus right now is in sunitinib, cabozantinib, and lenvatinib. Surufatinib, there was a study, a phase 3 study that was done by our Chinese collaborators, and actually we wanted to submit the data to the FDA for approval of sunitinib because we don't have that many options for small bowel neuroendocrine tumors as we have for the pancreas neuroendocrine tumors. That said, the FDA decided the patient population that were accrued were not the same as in the United States, and unfortunately it's not approved, but now MD Anderson has run in some of the studies with surufatinib. So more to look about surufatinib. Cabozantinib, the cabinet study is currently on phase 3, and we think that that's going to get approved, and we can see there is benefit on injected response, but that's in pancreas, mostly seen in pancreas neuroendocrine tumors, and then there's progression-free survival benefit. But also lenvatinib, this is from the TALENT study, and this is, we can see an overall objective response rate higher in pancreas neuroendocrine tumors compared to small bowel neuroendocrine tumors. This response rate is the highest out of all the tyrosine kinase inhibitors, with also progression-free survival benefit. I have used lenvatinib. I mean, this is just my own personal experience. Maybe I've been lucky, but I have seen some responses with lenvatinib in the third-line setting. Visulitant, as that was another drug recently approved for VHL-related tumors, mainly CNS hemangioblastoma, kidney cancers, as well as pancreas neuroendocrine tumors. I know I'm running out of time, so I want to discuss a few things. But this is something that I wanted to keep in mind, that the response rate seen on the pancreas neuroendocrine tumors was very striking. And that's something that we need to keep in mind because it's already FDA approved for VHL-related pancreas neuroendocrine tumors as well as other tumors. That say there is an ongoing study with visulitant as for not only for pheochromocytomas and paragangliomas, which is another subset where HIF is stabilized, but at the same time for pancreas neuroendocrine tumors sporadics. And one of the reasons is because up to 40% of patients with pancreas neuroendocrine tumors sporadic may have somatic VHL mutation. Something to look forward in terms of the data of these tumors. So these are very briefly, I'm going to discuss some of the recent trials. These are trials discussed at the ESMO and ASCO last year, as well as this year. The reason why I want to discuss this is because these two studies has been the first studies in terms of sequencing of treatment. In all neuroendocrine tumor studies, we actually have investigational drug versus placebo or investigational drug versus long-acting sandostatin, but we don't have any two active treatments. And that's the reason why I feel like these studies are very important, because one of the questions that we always get is like, what is the sequence of treatments? We don't have guidelines on what to do. We always treat our neuroendocrine tumors quite personalized, but we don't have guidelines on what to do. Like yesterday, I learned so much about hepatocellular carcinoma and cholangio. You have first line, second line, third line, but we don't have that for neuroendocrine tumors. And a lot of that has to do with discussion with the patients, what the data is showing, and what we think it may be best for the patient. But as we can see here, this is a sector study. This is a randomized study of patients that receive an streptozotocin plus 5-FU. This regimen is widely used in Europe. We don't use it that much here, and actually we don't have streptozotocin available in the United States. But this is still an important study because it tells us about the sequence of treatment. This was a randomized study of a patient receiving streptozotocin and 5-FU followed by everolimus versus everolimus once there was disease progression followed by streptozotocin and 5-FU. And basically what they say is that they show similar progression-free survival, but understandable with the cytotoxic chemotherapy, they saw higher response rate with streptozotocin and 5-FU. Even though it's not a treatment that is widely used in the United States, I still feel that based on the data that the Europeans have shown, it's still a regimen that we could consider. The oculorandom, this is another sequential treatment study, and this is the randomized study of patients either receiving dotatate versus sunitinib, and we can see here that the patients that were on receiving dotatate has a longer progression-free survival compared to sunitinib, and this is practice validated because now it can tell us, like, well, maybe you can use Lutathera as a second line before sunitinib. And then there is, of course, the alpha PRRT. This is very exciting. There is an ongoing phase 1 trial. The data was reported that say now there is ongoing phase 2 and phase 3 studies of alpha PRRT. And this is the dose that was recommended for the phase 2 studies, and then the responses rate was very striking as well. That's we still need to see the follow-up studies and see what is the efficacy on neuroendocrine tumors. But very exciting to see this alpha PRRT. And these patients that in the study, they included patients that previously received 177 lutetium dotatate as well as 177 lutetium dotatate naive. These are the recent studies for the pancreas neuroendocrine tumors. I don't have much time to discuss. This is something that will be available if you want to go back. But again, there has different studies for the high-grade neck. I didn't discuss much about the high-grade neuroendocrine tumors. We know that we follow the guidelines for the small cell lung cancer. That said, we still, there is ongoing studies for the high-grade neck. One thing that I wanted to mention is that we don't have data, and I see that from the oncologists in the community of giving cisplatin and etoposide plus atezo on the high-grade neuroendocrine carcinoma. There is an ongoing NCTN study, and there is 3 arms to the study. One is cisplatin and etoposide alone. The other one is cisplatin and etoposide plus atezo for 4 cycles, and then cisplatin and etoposide and atezo maintenance. So I'm very excited to look at the data of the study. That can definitely help us, but for as of now, I really don't recommend adding atezo for the high-grade neuroendocrine carcinomas because we don't have any data on efficacy. That said, if you ask me what do you do in the second-line setting, I usually recommend doing immunotherapy with ipi/nivo just on the DARTS data. I don't have time to discuss that, but this is some of the studies that has been reported this year on the ASCO and this year, and as well as the ESMO last year. And this is there is a NECT SEER2 study, which is an liposomal irinotecan plus 5-FU versus docetaxel. This is for the extrapulmonary neuroendocrine carcinoma. Overall, the combination of irinotecan plus 5-FU has longer 6-month progression-free survival, and that's the primary endpoint. We also have the other studies, is the FOLFIRI and bevacizumab versus FOLFIRI. There was no different overall survival between arms. Both arms had 6 months overall survival of greater than 50%, and that's one of the questions that they want to answer, but there was no benefit one to the other, or difference, I wanted to say one to the other. And this study is very interesting. I have to say that when this study was done, That was before the 2019 WHO classification. So a lot of the patients that were included on the study, besides having a grade 3 neuroendocrine carcinoma, they also included grade 3 neuroendocrine tumor. I think that it would be very important to do a separate study to include only the grade 3 neuroendocrine tumors. It was no superior captain compared to platinum topocyte, but we need to keep in mind that that was before the WHO classification of making the differentiation between the two, grade 3 NAT versus grade 3 NAC. And this is ongoing clinical trials. I'm not going to go into that, but when we have different grades of neuroendocrine tumors, available clinical trials, we're very excited about this study, which is in the adjuvant setting for pancreas neuroendocrine tumors. Dr. Suarez is the PI in the study, and then we have other studies available that's in case that, you can always go back here and explore these studies. This is almost my 2 slides. So in the first, for management of the GI neuroendocrine tumors, first-line treatment for well-differentiated small bowel neuroendocrine tumors for me is SSA. If there is progression of disease after SSA, then if the patient has a positive DOTA scans, we can consider PRT with 177 lutetium DOTA. If the patient has a negative DOTA scans, we can always consider everolimus in this setting. If progression of disease after PRT everolimus, we have the TKI as well as consider clinical trials. In patients in the management of pancreas neuroendocrine tumors, SSA is a first line. If there is disease progression, we need to determine what is the volume of disease. If the patient has symptoms rapidly growing, then we consider capecitabine temozolomide. Moderate volume, functional tumors, avidon, DOTA scans, we can consider PRT with 177 lutetium DOTA. If progression of disease after Lutathera of capecitabine temozolomide, then we have the other options, everolimus, lenvatinib, sunitinib. Clinical trials, that say we also need to consider the other options that we discussed earlier, like surgery, liver-directed therapy, and so forth. And this is the take-home point. Gastroenteropancreatic neuroendocrine tumors have heterogeneous biology that impacts prognosis and treatment. Treatment decisions are based on clinical pathologic criteria based on tumor size, differentiation, grade functional status, and if the patient has avid DOTA scan or not. We discussed that up to 30% of pancreas neuroendocrine tumors has produced hormones, and because of that, they have very specific clinical symptoms. Mid-gut neuroendocrine tumors often develop carcinoid syndrome. We have now many tools available, but again, something that we need to discuss as a multidisciplinary team to determine what is the best treatment for the patient. We still don't know what is the best sequencing. That said, I think there's always something that we need to discuss about all the treatment options available for the patient. MGMT status is associated with response rate in pancreas neuroendocrine tumors treated with temozolomide, something to keep in mind. That said, there is no routine assessment of non-specific biomarkers, and for now, we don't necessarily recommend it. And we need to tailor treatment for every patient. Treatment for every patient. We require careful balance of patient and treatment characteristics as well. And with that, I want to thank you for your attention. I know that I run out of time, so I have questions, and during the break, you can ask me any questions. Thank you.
Thank you. So for the interest of time, we'll take a break. In the exhibit room, there's some snacks that you all can grab, mingle with your colleagues, with the exhibitors. If you have any questions, you can ask then. And then we'll call you back in here shortly for the next presentation.